We welcome you all to this ASCO-endorsed CPOM Foundation webinar on modern management of bladder cancer, multidisciplinary perspectives. I am Dr. Vishwanath, Senior Consultant and Academic Advisor in the Department of Medical Oncology at Apollo Hospitals, Bangalore, and also the Managing Trustee of the CPOM Foundation. I'm truly delighted to be your host for this session. We will have a very high-impact 90-minute program and featuring global experts and national leaders covering various aspects of bladder cancer, including systemic therapy, surgical strategies, metastatic disease, and also the novel drugs. This webinar is brought to you by the CPOM Foundation with endorsement from ASCO and also support from AstraZeneca, Intas, NATCO, and OncoMinds. For those who are new to CPOM, CPOM stands for Creative Portal for Oncology Education and More. CPOM is a not-for-profit organization tasked with educating practicing oncologists and trainees. And it's also a portal for increasing access to patient resources and improving awareness globally. So this is the CPOM team. Myself, Dr. Vishwanath is the managing trustee, and also the co-founder, Dr. Santosh Kumar Devdas from MS Ramaya, also the co-founder and trustee. And we have three other trustees, Dr. Poonam Maurya from Apollo Hospitals, Dr. Rachin Shetty from AG Hospitals in Mangalore, and Dr. Chandrakant MD from Narayana Hospitals in Kolkata. A few ground rules before we start. Please ensure that you have a stable internet connection for a seamless experience. All attendees are in mute and listen-only mode. You may ask questions via the Q&A section. We will address as many as time permits. And this session is being recorded and may be shared later for educational purposes. So let's move on to the first speaker. The first session's chairperson is Dr. Santosh Kumar Devdas. He is the professor and head of the Department of Medical Oncology at the MS Ramaya Institute of Oncosciences. And over to you, Dr. Santosh, to introduce the first speaker and take over the first session.
Thank you, Dr. Vishwanath. Let us kick off the first talk by Dr. Daniel Petrylak. It's indeed a great honor for us to have Dr. Daniel Petrylak with us today, who is a professor of medicine and urology and the chief of genitourinary oncology at Smilow Cancer Center, Yale School of Medicine. Dr. Daniel Petrylak is a pioneer in the research and development of new drugs and treatment to fight prostate, bladder, kidney, and testicular cancers. Dr. Petrylak received his MD from Case Western Reserve University School of Medicine, completed his internship and residency at Albert Einstein College of Medicine, and his fellowship in medical oncology at the Memorial Sloan Kettering Cancer Center. He joined as a faculty of Yale in 2012. In addition to his role as a professor, he is also a member of the Cancer Signaling Networks Research Program at Yale Cancer Center. Dr. Petrylak currently serves as either the principal investigator or co-principal investigator on 7 SWOG clinical trials for genitourinary cancers. To date, he has authored more than 200 peer-reviewed articles on prostate and bladder cancer research. He will be talking on neoadjuvant and adjuvant systemic therapy in muscle-invasive bladder cancer. What is the latest? Over to you, Dr. Petrylak.
Good morning. Good morning, and thank you for the kind introduction and the invitation to speak. So, thank you again for the lovely introduction and the chance to speak here. I unfortunately have never visited India, but I guess this is the best next thing, being able to speak to you. So we're going to be talking about neoadjuvant and adjuvant therapy for muscle-invasive urothelial carcinoma. And as we know for patients with bladder cancer, about 70% are eligible to receive cisplatin-based chemotherapy. And the different criteria for cisplatin-based chemotherapy include those patients who have adequate renal function, who don't have comorbidities such as peripheral neuropathy or cardiac disease, and also patients who have good performance status. And as I said a moment ago, that encompasses about 70% of patients with locally advanced urothelial carcinoma. Cisplatin-based chemotherapy has been the mainstay of treatment for for those patients with muscle-invasive urothelial carcinoma, and neoadjuvant therapy is generally given for about anywhere between 8 to 12 weeks prior to cystectomy. And when we look at a conglomerate of cisplatin-based trials, there's approximately a 14% reduction in the risk of death for those patients who undergo neoadjuvant chemotherapy. The benefit appears to be predominantly in those patients who have a complete pathologic response. As we see from this hazard plot, those patients who overall the hazard ratio is 0.87, and this is from a variety of different clinical trials that have used platinum-based chemotherapy, either single agent or in combination. So the question, of course, is we have this as our basis for treatment for urothelial carcinoma. What is the role of checkpoint inhibition therapy in muscle-invasive urothelial carcinoma? Well, we have two different areas where checkpoint therapy is used. One is in the adjuvant setting, and then now there's data in the neoadjuvant setting as well. I'll first handle those positive trials that have been performed with neoadjuvant therapy. So Checkmate 274 is a phase 3 trial, double-blinded, that looked at adjuvant nivolumab compared to placebo in those patients who have high-risk urothelial carcinoma, muscle invasive. So there are two different groups. There are those who had prior neoadjuvant therapy, and they had to have T2 disease or higher. It could be T2 with any degree of lymph node involvement. And then those patients who have not had neoadjuvant therapy, their stage had to be a little bit higher. They had to be T3 to T4. And they could, of course, as I mentioned before, they could not have had neoadjuvant therapy. They had to have surgery within 120 days of randomization, and they had to be disease-free. And they were randomized to receive nivolumab every other week at 240 milligrams versus placebo. And the patients were treated for up to 1 year of adjuvant treatment with nivolumab. As we see here, in both from the intent to treat population, as well as the PD-L1 positive population, there's improvement in disease-free survival in favor of nivolumab compared to placebo. It's 22 months with nivolumab. With placebo, it's 11 months. So it's basically doubling of the disease-free survival. It's more pronounced in those patients who have PD-L1 positive disease, 53 months versus 8.4 months. If we look at this in terms of distant metastatic disease, we again see an improvement in the development of distant mets. It's about a 20-month improvement over placebo in the intent to treat population. It's not reached in those patients with PD-L1 positive. So another trial, which Dr. Sonpavde and I have had the good pleasure of being co-authors on, this was led by Dr. Apollo from the cooperative groups. It was a randomized trial of pembrolizumab versus observation in patients with muscle-invasive bladder cancer who have undergone cystectomy. This also included upper tract disease as well. And these patients had to be T2 or higher if they were a post-neoadjuvant, and again, T3 or higher if they did not receive neoadjuvant therapy. And a similar improvement in disease-free survival was seen. These are overall the clinical characteristics of patients, predominantly patients with bladder cancer, upper tract disease, and about a quarter of patients overall. Again, as I mentioned before, there was a similar improvement in disease-free survival in favor of pembrolizumab. This trial was unblinded at the time of the nivolumab dissemination of data, and thus there isn't any survival data on this, but the median follow-up was 44.8 months. As you can see, there's about a 15-month improvement in disease-free survival in favor of pembrolizumab. I'm not going to show the data here, but I'll note that a similar difference was not seen with atezolizumab. So 2 of those 3 adjuvant trials were positive. Atezolizumab was negative. The reason, there are multiple reasons for that. Could be that there's a difference in checkpoint inhibitors. And I think personally, that's what I think that the difference is. There may be different activity. But nonetheless, those 2 particular agents do show phase 3 data in the adjuvant setting. So, of course, we'd like to move neoadjuvant checkpoint therapy up to the neoadjuvant setting, and this was the hypothesis behind Niagara. These were cisplatin-eligible patients, and they had to have muscle-invasive disease. They were randomized to receive the combination of gemcitabine and cisplatin with or without durvalumab, the durvalumab and gemcitabine combination was administered for 4 cycles, which is 12 weeks. Patients then underwent a radical cystectomy, and if they were in the durvalumab arm, they were allowed to receive adjuvant durvalumab for up to 8 cycles post-cystectomy. In the gem-cis arm, there was no treatment. The dual primary endpoints were event-free survival and pathological complete response rate, and the key secondary endpoint was overall survival. These are the patient characteristics. If we start looking at PD-L1 expression, PD-L1 high was about 3/4 of patients, low was about 1/4 of patients, predominantly Caucasian, about 1/4 of patients being Asian, 2% African American, and nodal disease, regional nodes were positive, about 5% of patients overall. If you look at the pathological complete response, if there were 2 different analyses, one in January of 2022, and there was a reanalysis in April of 2024, about 1/3 of patients in the durvalumab arm had a pathological complete response. About 1/4 of patients had a pathological complete response in the gemcitabine and cisplatin arm. If we look at the event-free survival on an intent to treat basis, we see that there's an improvement with the addition of checkpoint therapy with durvalumab. The median event-free survival was not reached in the durvalumab arm. In the gem-cis arm, it was approximately 46 months. Hazard ratio is 0.68. If we look at the overall survival, there's about a 25% improvement in the overall survival in favor of the combination arm versus the gem-cis arm. Now, if we look at adverse events, there's really nothing here that's surprising. It's really what we would expect when we give both agents separately: nausea, anemia, constipation, fatigue, urinary tract infections, and then we start seeing a little bit more diarrhea and asthenia. This is the same in both arms, but with the combination, we start seeing more diarrhea, more immune checkpoint-related types of reactions, more pruritus overall, but again, fairly well tolerated. So this is for patients who have cisplatin eligibility. And then there was an interesting sub-analysis that was performed at the presented at the ASCO meeting this year, looking at circulating tumor DNA results in patients who underwent a radical cystectomy on this particular trial. So there were different points at which these particular measurements were made. Patients had circulating tumor DNA measured at baseline. Overall, that was 57% of all patients. Pre-radical cystectomy and then post-radical cystectomy, about 1/4 of patients had positive CTCs at pre-radical cystectomy, a little bit higher in the comparator arm versus the durvalumab arm, and post-radical cystectomy was also a little bit higher as well. And of course, we had an adjuvant component to this trial. So if we start looking at the event-free survival in terms of the combined arms, this is the perioperative measurement of circulating tumor DNA. Circulating tumor DNA did predict events-free survival. On the right, you see the different arms separately, the blue being the neoadjuvant chemotherapy, and the green being the control arm. And then we also see that the clearance was higher in the durvalumab arm as well. Pre-cystectomy, 70%. Versus 57% for the comparator, and there was a higher rate of circulating tumor DNA clearance, again, as you see from the Kaplan-Meier curves on the right. Same thing with disease-free survival post-cystectomy. If circulating tumor DNA is detected, there's a higher rate of relapse than those patients who do not have circulating tumor DNA. So there's some questions that are raised by Niagara. So do patients who achieve a pathological complete response still need adjuvant therapy? As we know in the 2 trials I talked about before with nivolumab and pembrolizumab, those are patients who had residual disease. Those were not pathological complete response patients. Is there any role for dose-dense MVAC? And then, of course, in the comparator arm on Niagara, there wasn't adjuvant therapy that was administered. At least only 5% of patients received that. So did that affect the overall results? And I think these are important questions to be answered in the future. Moving on to patients who are not eligible to receive cisplatin, there's some data that's been generated with enfortumab vedotin. Guru is going to be talking more about this in the metastatic state, but as we know, this is an antibody drug conjugate that recognizes Nectin-4. Nectin-4 is expressed in approximately 90% of urothelial carcinoma specimens. And we've actually done several different clinical trials looking at enfortumab vedotin in those patients who are ineligible to receive cisplatin-based chemotherapy. So this was some data that I reported at ASCO ASCO GU a couple of years ago, looking at those patients who are ineligible to receive cisplatin. There was predominantly those patients who had renal dysfunction. They received 3 cycles of neoadjuvant enfortumab vedotin, and then they went on to receive radical cystectomy. This patient was a 20-patient cohort, and predominantly those patients who were ineligible to receive cisplatin were ineligible because of a low creatinine clearance, 50%, hearing loss in 49%, and 4.5% of patients, just one patient who had both hearing loss as well as creatinine clearance that was less than 60. If you look at the pathological complete response rate, this is comparable to what we see with dose-dense MVAC as well as nivolumab, gemcitabine, cisplatin, 36.4%. Pathological downstaging was 50%. And the one thing that we were concerned about was we did have 3 toxic deaths on this study. They were not attributed to enfortumab. One was a cardiac arrest, another one was acute kidney injury, and a third was pulmonary embolism. These were post-radical cystectomy. Other adverse events, and Guru is going to probably talk more about this in his section. Peripheral neuropathy is seen in about a third of patients. Skin rash, any degree, any grade, 63%, and cutaneous adverse events, 9.1% overall. Hyperglycemia is something we need to be concerned about with enfortumab. About a quarter of patients had hyperglycemia. Now, looking at this in terms of other neoadjuvant therapies, this seems to be comparable. And this, of course, will open up, if this is a true observation, randomized trials, this would open up the cisplatin ineligible patients to being eligible to receive some form of neoadjuvant treatment. Cohort L, very similar to what we had in cohort H. Initially, the same induction regimen. However, the patients did receive adjuvant EV for 6 cycles after surgery. And there was a neoadjuvant and adjuvant phase. In this report, we're seeing that 82% of patients completed all 3 cycles of neoadjuvant therapy. If we look at the pathological complete response rate, similar to what we saw in cohort H, 34 overall 34% pathological complete response rate, downstaging rate of 42%. Treatment-related adverse events similar to what we saw in the cohort H. These were predominantly skin-related issues as well as peripheral neuropathy. Now, we've actually combined this data, and this was presented at ASCO this year, looking at the 1-year and 2-year event-free survival rates, 76.4% at 1 year, 62% at 2 years. And if we look at those patients who received a pathological complete response, of course, as one would expect, that's somewhat better. 87 versus 69% at 1 year, 87 versus 46% at 2 years, and at 3 years, 72% versus 46%. And the overall survival at 2 years is 77%, and at 3 years is 68.2%. So, of course, we'd like to combine these particular combinations, and there are 2 randomized trials that I think are of note. There's Keynote 095, which took patients who were cisplatin ineligible, or those patients who were cisplatin ineligible who declined standard cisplatin chemotherapy. And there were 3 different arms to this trial: pembrolizumab, observation, or pembrolizumab combined with enfortumab vedotin. And then these patients underwent a cystectomy, and they were eligible to receive in arm C adjuvant therapy after the cystectomy. So this trial is currently close to accrual, and it's maturing. And then there's the Volga study, which was for those patients who were cisplatin ineligible. They were randomized to 1 of 3 arms: durvalumab, tremelimumab, and enfortumab, durvalumab combined with enfortumab, or they went straight on to cystectomy, which would be considered to be standard of care. This is a fairly difficult design to go forth with. Guru and I were involved in a trial in SWOG that unfortunately did not accrue because of the cystectomy arm, and it's hard to randomize patients to a cystectomy only arm. But this trial is also close to accrual, and the data is maturing. So in conclusion, GemCis durvalumab is a standard of care for neoadjuvant therapy of muscle-invasive bladder cancer. Single-agent enfortumab has pathological complete response rates of 34% in locally advanced cisplatin-ineligible patients. Phase 3 studies are evaluating neoadjuvant enfortumab combined with checkpoint inhibitors, and these trials have completed accrual, and circulating tumor DNA can be used to identify patients for high risk of relapse post-cystectomy. Thank you for your attention.
Thank you, Dr. Petrylak, for that wonderful overview of the current trends of neoadjuvant as well as the adjuvant checkpoint inhibitors. So moving on, let me share this. So now I have the pleasure of chairing this session, and so our speaker is Dr. Ashwin Mallya. He's a dear friend, and he's a senior consultant urologist, uro-oncologist, and robotic surgeon at Sir Gangaram Hospitals in New Delhi. And he specializes in the management of prostate, kidney, and urinary bladder cancers with a focus on robot-assisted and minimally invasive surgeries in uro-oncology. He completed his medical and surgical training from the Kasturba Medical College in Bangalore, and his super specialty in urology from the Institute of Nephrourology in Bangalore. He also holds the MRCS from the Royal College of Surgeons of Edinburgh. Dr. Mallya pursued an advanced fellowship in robotic oncology at the Medanta, the Medicity hospitals. He has trained internationally through observerships and visiting faculty roles at various high-volume centers like the University College London hospitals in UK, Global Robotics Institute in Orlando, Florida, and also the Keck School of Medicine, University of Southern California, United States. He's also very academically inclined, and he has over 30 PubMed index publications, received several awards, including the Young Urologist Award by the Urological Association of Asia in 2018, and also the USI Olympus International Travel Fellowship to Europe awarded by the Urological Society of India in 2015. Over to you, Dr. Ashwin Mallya, for your talk on surgical management in bladder cancer, radical cystectomy, and bladder preservation strategies.
Thank you, Dr. Vishwanath, for that beautiful introduction. I would like to share my screen, if that's okay.
Yeah, you can.
First of all, I'd like to thank the CPOM Foundation led by Dr. Vishwanath and his able team for giving me an opportunity to present in this webinar. It is indeed a privilege to be sitting amidst some world-renowned authorities in the field of uro-oncology, Dr. Petrylak and Dr. Guru Sonpavde. I think I might be one of the few, surgeons in the audience, totally in this webinar. So I hope I do justice from that point of view. So I'll be discussing surgical management in bladder cancer, radical cystectomy, and bladder preservation strategies. So I have no disclosures. So what will I be covering in this presentation? So first of all, TURBT is the most important sacrosanct staging procedure. I'd be covering that. I'd be going through some of the intravesical therapies that we have. Then we'll go on to radical cystectomy and diversions, and how neoadjuvant chemo or immunotherapy is affecting outcomes. And we'll talk something about bladder preservation strategies. So what are the components of a standard TURBT? So it's the cornerstone of bladder cancer diagnosis. So we always do a TURBT, that's a transurethral resection of a bladder tumor under general anesthesia or spinal anesthesia with obturator block. The cystoscope that we use is a 30-degree cystoscope and 70 degrees sometimes to visualize some difficult to visualize areas of the urinary bladder. A thorough bladder mapping is necessary, as in each area of the bladder should be thoroughly mapped out, not to miss out any smaller tumors or foci of carcinoma in situ. We generally do piecemeal resection of the tumor. The deep muscle biopsy is always sent separately, and that's very important to have when we are doing a TURBT. Random biopsies are always taken. Sometimes taken because the cytology might be positive and we might be seeing a very low grade kind of tumor. So we want to make sure that we don't have any other high grade foci. And because cytology is generally positive in high grade tumors, a good hemostasis is achieved, and irrigation occurs for a few hours to prevent any clot formation with normal saline. And post-operatively, generally for low-risk tumors, we are giving post-operative intravesical mitomycin C, single dose instillation, which has been found to decrease the recurrence. So once we do the TURBT, so these are the different depths of invasion that we may have. We may have a tumor in situ or a carcinoma in situ, a TA, which is a non-invasive papillary carcinoma, a T1, which might be a tumor that might be invading the subepithelial connective tissue. T2 invades muscle. T2A is superficial, and T2B is the deeper layer of the superficial, of the deeper layer of the muscle. And T3 is when it invades the perivesical tissue, and T4 is when it invades adjacent tissues and organs. And again, the grade might be a pun lump, a low grade, or a high grade. So whenever we have a high grade on TURBT, we definitely recommend a restaging TURBT because the chance of upstaging is around 20 to 25%, more so if deep muscle is not present in the initial biopsy. And so we may have a low grade or a high grade, or the depth of invasion may be a TA, T1, T2, or a T2. And depending on that, the decision making is done. So how can we improve the quality of TURBT? It's very important to standardize this because it helps in communication and quality control. On-block resections are helpful when there are smaller tumors less than 2 centimeters, wherein the complete lesion is removed as an on-block along with the deep muscle. So we can use certain image enhancement techniques like narrowband imaging, which helps us to visualize difficult to diagnose structures within the bladder. For sometimes we may be doubtful whether is this a tumor, or there might be a cytology positive and we might not be finding tumors. So this helps us to find those tumors. Blue light cystoscopy, which comes under photodynamic diagnosis. So that also is helpful to find all the tumors. And a restaging TURBT is helpful in upstaging. So these photographs show how a tumor looks under various imagings. For example, the white light cystoscopy, we might see a tumor, which is seen here. This is a small papillary tumor around 1 to 1.5 centimeters. So when you use blue light cystoscopy, the tumor looks red, and the surrounding normal epithelium, normal mucosa looks bluish. So the narrowband imaging, again, we can see how the tumor looks. And there is another technique called confocal laser endomicroscopy, which is still being studied, wherein it provides real-time histology type images. So what has been found is that photodynamic diagnosis and narrowband imaging improves the detection, decreases the recurrence at short and long term, but no evidence that it prevents progression. Generally, when people are getting intravesical BCG, we try to keep at least a 6-week gap because on blue light cystoscopy, because there is false positivity that might appear if we use it too soon after a BCG. And more studies are needed for confocal laser endomicroscopy for it to become standard practice. So again, moving on to decision making after a TURBT. Suppose it's a non-muscle invasive bladder cancer. So generally, depending on whether it's a low risk or a high risk, we decide on whether we have to give mitomycin C in low grade and gemcitabine docetaxel in high grade. So the other standard of care for high grade tumors is intravesical BCG, which is the workhorse of our NMI-BC management, wherein we give induction, 6 weeks induction, that is weekly installations of BCG for 6 consecutive weeks, followed by 3 weekly installations at 3-month intervals till 2 years, and while doing 3 monthly cystoscopies to look for recurrence or progression. So this is the SWOG regimen. So in BCG refractory or relapsing disease, so the options that we have are early cystectomy moving on to gemcitabine docetaxel, which is again, which again, some of the earlier studies have been done from the United States University of Iowa, and so using this has kind of like a synergistic effect where gemcitabine is a cytotoxic agent, and docetaxel, prevents, it inhibits microtubules. So it acts in tandem and prevents, recurrence and progression. So when BCG refractory disease or relapsing disease is found, other newer modalities are intravesical interferon alpha 2b gene therapy in the form of nadofaragene, and intravenous pembrolizumab has been tried. This is as a result of the Keynote 057 trial, and hyperthermic mitomycin, which improves the penetration of mitomycin into the cancer cells. So mitomycin is delivered at around 42 degrees Celsius, so which improves the penetration of this agent into the cancer cells. So what next if it is muscle invasive bladder cancer or locally advanced? In the standard practice in our center is to refer the patient to the medical oncologist who gives neoadjuvant chemotherapy, which could be gemcitabine or a DD-MVAC. And moving on to, after that, we do a radical cystectomy and pelvic lymph node dissection with ileal conduit or an orthotopic neobladder. So the other option is to do a radical cystectomy directly if the patient has not undergone chemo. This followed by adjuvant chemo if there is an indication for that. Or now with the newer studies like the Niagara trial, so neoadjuvant immune oncology drugs like durvalumab along with chemo, followed by radical cystectomy, and followed again by adjuvant durvalumab. So what are the bladder preservation strategies? Now, if a patient is desirous of preserving his bladder, and if patient is eligible to preserve the bladder, in this case, the trimodality therapy can be used, concurrent chemoradiation can be used, and partial cystectomy along with radiation can be used. So I am often asked by patients and even medical oncologists, is this patient eligible for a partial cystectomy? So partial cystectomy can be used in very selective cases where the tumor, for example, is present in the dome. It's strictly a T2 kind of tumor. No CIS changes in the rest of the bladder, which is situated well away from the bladder neck and the urethra. And, so there should be good functional bladder capacity. Otherwise, we cannot use partial cystectomy because it won't do justice to the disease. So what is the standard of care for bladder preservation? The best candidates are histologically confirmed MIBC, which more than or equal to PT2, node negative, non-metastatic, ECOG 0 to 2, no previous pelvic radiation, adequate bladder function, and adequate renal and bone marrow therapy, bone marrow function for chemotherapy. So we perform a maximal TURBT, as in our attempt is to make sure that the tumor is completely resected. This is followed by neoadjuvant chemo. This is followed by radiotherapy with the radiosensitizing agent, that is 55 grays in 20 fraction, along with the radiosensitizer. And this is followed up with repeat cystoscopy every 3 months for 2 years and every 6 months for further 2 years, and then annually. So annual CT staging should be done, and you should consider radical cystectomy for local invasive recurrences. So as you see, it's not a cakewalk when a patient has a bladder preservation. He has to be very compliant, and repeated hospital admissions or have to be made for doing these cystoscopies. So the patient has to be a very compliant person to have bladder preservation strategies. So what do real-world studies tell about trimodality therapy? So trimodality therapy was studied. This is one of the studies I found in Lancet Oncology by Zlota et al., where there are no randomized controlled trials comparing trimodality therapy and radical cystectomy, but this was a propensity score matched analysis where finally 440 radical cystectomies were compared to 282 trimodality therapy patients. There was no difference in metastasis-free survival or cancer-specific survival, but the overall survival favored trimodality therapy. The salvage cystectomy rates were 13%, which is a much more difficult cystectomy for us to perform. In bladder recurrences were 31%, and pelvic recurrences were 8% in trimodality therapy as compared to only 3% in radical cystectomy patients. So what does a radical cystectomy entail? So this is a recent radical cystectomy specimen of mine, where the distalmost end of the ureter, the urinary bladder, the seminal vesicles, the prostate, and the lymph nodes, which are along the external iliac, the obturator, and the internal iliac are definitely removed. And most of our patients come to us after neoadjuvant chemo, and this is generally a 4 to 6 hour procedure, 5 to 8 day stay on an average. The complications could be bowel issues, which is the Achilles heel sometimes of radical cystectomies, ureteral stricture formation, renal deterioration because of the ileal conduit or the neobladder. Readmission rates can go up to 20%, and 90-day mortality rates are 3 to 5%. So what has changed? So now with newer advances, there's better quality of life following surgery, faster recovery, so lesser blood loss, oncologic results. Now we have a large body of evidence. What used to be around 62 to 66% 5-year cancer-specific survival in the Hotman series. Now what has changed is introduction of robotics, introduction of enhanced recovery protocols, introduction of alvemopan, which decreases the ileus following the surgery. So ERAS protocols are followed in almost all high volume radical cystectomy centers now. This has been a game changer in improving the early discharge rates among our patients and early recovery rates. And this has really helped centers take up radical cystectomy in a big way. So what do we have in terms of evidence when it comes to robot-assisted radical cystectomy? So this trial, again, a multicentric trial from the United States, the RAZOR trial proved not only that there was less blood loss or earlier recovery following robotic radical cystectomy, but also went on to show equivalent oncologic outcomes in terms of no difference in recurrence, progression-free survival, or overall survival at 3 years for robotic versus open radical cystectomy. So another study from the NHS in the United Kingdom, the IROC trial, showed that robotic radical cystectomy had better median days alive and out of the hospital following radical cystectomy. This was, again, a multicentric study. So the robot-assisted radical cystectomies are here to stay, and they not only improve the early outcomes in terms of recovery and return to work, but they also have equivalent oncologic outcomes as open surgery. So what about the decision-making about ileal conduit versus an orthotopic neobladder or a pouch, continent catheterizable pouch? Again, it depends on the renal function, what kind of, to have a continent pouch or to have a neobladder, the patient must have very good renal function. So that is definitely a factor. And the patient must be willing for CIC, which is clean intermittent catheterization. There could be a prolonged, there could be a delay in continence in neobladder. So the innovation takes time to return, and patients may continue to have incontinence for a long period of time. So the patient must be aware of all these considerations. So what do the systematic reviews and meta-analysis say about the neoadjuvant chemotherapy? So this was a systematic review and meta-analysis comparing MVAC and GC, gemcitabine cisplatin. So the pathologic complete response rates were similar. The overall survival favored MVAC, but the VESPER trial showed that the progression-free survival and overall survival in the neoadjuvant subgroup was better in the DD-MVAC group as compared to the gemcitabine cisplatin group. So Dr. Petrylak has spoken about the Niagara study design and the outcomes, so I won't be going through that again. So how does it affect me as a surgeon? How does neoadjuvant treatment affect my surgical treatment? So what I have found is, and what has been supported by literature is that there is a good amount of tissue edema and fibrosis, which is common after neoadjuvant chemotherapy leading to difficult planes. This has been published by Froner et al. And Yaffe et al., who found that it is feasible and safe, even though there is tissue edema and fibrosis. And post-immunotherapy, so we are developing our experience, and I've had the chance to operate on 3 patients who underwent durvalumab, prior to, along with the gemcitabine cisplatin. We did find that the planes are difficult, but we did not require any conversion. But the literature says that around 10 to 15% required conversion due to difficult dissection. Another consideration is that immune oncology drugs cause a lot of immune cell infiltration, which might complicate the pathology. So this has, again, Dr. Petrylak went through some of this. So I won't be going through again about the guidelines, contemporary guidelines. So my take-home messages would be that TURBT remains the cornerstone of initial diagnosis and staging. Image enhancement can lead to improved TURBT. Intravesical therapy with BCG or chemotherapy are options for the non-muscle invasive bladder cancers. Radical cystectomies are increasingly being performed for high-risk NMIBC, BCG refractory disease. And neoadjuvant chemo followed by radical cystectomy remains the standard of care. Trimodality therapy is suitable for patients who are not fit for radical cystectomy or not willing for the same, and entails maximal TURBT, neoadjuvant chemo, and concurrent chemo-RT. Neoadjuvant immune oncology drugs like durvalumab in the peri-op setting with neoadjuvant chemo was studied in the Niagara trial, had better event-free survival, pathologic complete response, and overall survival compared to neoadjuvant chemo alone. With that, I'd like to finish my talk. Thank you very much.
Thank you, Ashwin, Dr. Ashwin Mallya, for that wonderful talk and critically laying down the differences about how to go about the radical as well as the trimodality treatment, radical cystectomy and trimodality treatment. It was a wonderful talk, and I'm sure our fellows will also keep you busy during the panel discussion. Moving on, let's move on to the next session will be chaired by Dr. Poonam Maurya. And Dr. Poonam Maurya is senior consultant in medical oncology at Apollo Hospitals in Bangalore. And over to you, Dr. Maurya, to introduce Dr. Guru Sonpavde.
Hi, good evening, good morning to all from wherever you are. Am I audible?
Yes, Dr. Poonam. Please go ahead.
Thank you. It's a pleasure to introduce our next speaker. We had such wonderful talks. So now it's a pleasure to introduce Dr. Guru Sonpavde, sir. He is a director of genitourinary oncology and phase 1 clinical research at Advent Health Cancer Institute, Orlando. And he's also has been the chair for bladder cancer research, professor of medicine, University of Central Florida. And Dr. Sonpavde is a leading expert in genitourinary cancers with a primary focus on bladder cancer. Has previously held faculty and leadership roles at Dana-Farber, University of Alabama, and Texas Oncology. He's trained in CMC Vellore, India, and US Indiana University. He has authored over 500 PubMed index publications and also co-leads multiple phase 1 to 3 clinical trials. A dedicated educator and mentor. He's active in national cooperative groups, SWOG, NCI, GU Task Force. His work has been featured in major medical and lay media, including the Time magazine 2024. So it's a pleasure to welcome Dr. Guru Sonpavde, sir, for the advanced and metastatic breast cancer management optimizing outcomes in this immunotherapy era. Over to you, sir.
Thank you, Poonam. So I'm going to share my slide set, Vishwanath and Poonam. Let me see. Great, and thank you for the invite. So my task is to discuss advanced bladder cancer optimizing outcomes in the era of immunotherapy. These are my disclosures. So just to tell you a story as it evolved, we've had cisplatin-based combination chemotherapy, GemCis, MVAC, for a long time until very recently, a few years ago. And these patients were treated as being cisplatin eligible versus ineligible based on performance status, renal function. And as you can see, in cisplatin eligible patients, the median survival was 14 to 15 months with GC, GemCis, or MVAC, or sometimes dose-dense MVAC in other trials. One thing I wanted to highlight was with GemCis, we do achieve probably a small cure rate. You see the tail to the curve, approximately 10 to 15% of patients still alive more than 5 years out. Whereas with gem carbo, we don't achieve a cure. The curves are falling down to 0%. Now, in the era of immune checkpoint inhibitor therapy, we have several immune checkpoints, which when you inhibit, you unleash the immune system. And of course, the two classes of drugs where we made most progress is PD-1, PD-L1 inhibitors and TLF4 inhibitors. So to tell you a story as it evolved, we initially had pembrolizumab emerging with full approval based on this phase 3 trial in the post-platinum setting, progressive disease, where pembrolizumab improved outcomes compared to historical taxane or vinflunine chemotherapy. As you can see, the median survival improved approximately 3 months from 7.3 to 10.3 months. The hazard ratio is 0.7, but most impressive was the tail of the curve where you see a 2-year survival approximately doubling from 14% to 27%. Now, of course, pembrolizumab is a PD-1 inhibitor and has some immune adverse event toxicities seen in approximately 15 to 20% of patients, as shown here, but these are usually manageable with therapies which we all have used in the clinic. Now, what made sense was to use an immune checkpoint inhibitor instead of waiting for progressive disease post-platinum. Why not get into the maintenance space in patients who are stable or responding to platinum-based chemotherapy? And this was tried in the Javelin Bladder 100 trial with the drug avelumab, a PD-L1 inhibitor, in patients who had stable disease or responding disease on 4 to 6 cycles of platinum-based chemotherapy. And in this trial, as you can see, there was an improvement in outcomes. The survival improved from 15 months for best supportive care to almost 2 years for supportive maintenance therapy with avelumab. The PFS also improved, as you can see. So this did lead to a change in the standard of care. But the problem with the Javelin paradigm is that the real world utilization of maintenance avelumab was low. And this is because a lot of patients are not in good shape to receive avelumab, either because they did not have stable or responding disease, or they progressed while waiting to get on avelumab. I've seen that happen myself in clinic many times. And sometimes it's comorbidities that did not allow maintenance avelumab. So really in the real world, as you can see in this real world study, only 20% of all patients who started platinum-based chemotherapy went on to get maintenance avelumab. So really the problem is the applicability of the Javelin paradigm in the clinic. Now, what about first-line PD-1, PD-L1 inhibition, especially in cisplatin ineligible patients where we know we have poor outcomes with gem carbo? Median survival with gem carbo was less than a year. So why not look at these agents monotherapy first line? As you can see, approximately 25% response rate with pembro or atezo in the first line. Initially, there was wider approval, but later this has been whittled down to really, at the moment, only pembrolizumab surviving as monotherapy in platinum ineligible patients. So really patients ineligible for both cisplatin or carboplatin. So really unfit patients. And this evolved because of negative phase 3 trials, which I will show you soon. Now, do we have a biomarker to select patients for PD-1 inhibition? So there is no optimal biomarker. There are studies that have been done, and essentially the luminal cluster subtyping, high mutation burden, PDL1, IHC expression, CD8 T cell infiltration, all of these correlate, but they're not optimal. And if you combine all of these, maybe you can improve the power of the predictive ability of these biomarkers. But at the moment, we don't have a biomarker in clinic to select patients for monotherapy with PD-1, PD-L1 inhibition. And there is some more recent data of ctDNA. The ctDNA would be basically tumor-informed ctDNA as looked at in this study I show you here. Essentially lower baseline tumor-informed variant allele fraction was associated with improved best overall response. And also a change, serial changes in the ctDNA were also associated with outcomes, more with pembrolizumab than with chemotherapy, suggesting that a change is more relevant in the immune checkpoint inhibitor setting because the responses are more durable in the immune checkpoint inhibitor setting. Now, how about combined immune checkpoint inhibition? So this was a study which looked at durvalumab, tremelimumab as first-line therapy in advanced urothelial carcinoma. The overall study was negative. However, the interesting finding in the secondary analysis was that in the PD-L1 high group, there was a favorable outcomes in the durva-tremi arm. So this gave us a ray of hope. So maybe a chemotherapy-free regimen could make it to the first-line space. And indeed, the Checkmate 901 trial looked at this. This trial looked at various different comparisons. One of them is the GemCis-Nivo comparison, which I will show you soon. But I want to highlight here the Ipi-Nivo arm. Ipi-Nivo was compared with Gem-Carbo in cisplatin ineligible patients. And the second comparison compared Ipi-Nivo versus Gem-Platinum in PD-L1 high patients. And in this case, the platinum could be cisplatin or carboplatin. And unfortunately, the overall trial was negative with this Ipi-Nivo comparison. So in cisplatin ineligible patients, the overall survival hazard ratio was 0.79, and the p-value did not meet the pre-specified bar for statistical significance, unfortunately, despite the hazard ratio looking trending certainly towards Ipi-Nivo, median survival 19 months versus 13 months for Gem-Carbo. And also the other comparison in PD-L1 high patients, Gem-Platinum, where the platinum was cis or carbo, versus Ipi-Nivo, that comparison was also negative. Hazard ratio was less impressive here, 0.87. So unfortunately, Ipi-Nivo could not make it to the first-line space. However, there were hints of significant activity in a subset of patients. The objective response rate around 35% in each of these groups, Gem-Carbo and Ipi-Nivo. As you can see, the CR rate more impressive for Ipi-Nivo, approximately 15%. And also, when you look at the right-hand side and look at the duration of response, the median duration of response, if you responded to Ipi-Nivo, was 25 months, so around 2 years. That's impressive. Whereas with Gem-Carbo is the typical chemotherapy a short duration of response, 7.4 months. So unfortunately, Ipi-Nivo did not make it at the end of the day based on those comparisons in Checkmate 901. What about the chemo-IO combination? So these are a couple of trials, which combine immune checkpoint inhibition, either Pembro or Atezo, with Gem-Platinum. The platinum could be. At the end of the day, both of these trials are negative. There were some trends, but just the bar. And these are trials which are comparisons of monotherapy. And basically, this negative study with the first hierarchical testing negative study of the triplet led to the monotherapy being disapproved, except for Pembro surviving in platinum ineligible patients. Now, moving on to the study more recently done, Checkmate 901. So in both the previous studies, which looked at Pembro or Atezo in combination with Gem-Platinum, there were hints that cisplatin-based backbone might be better, might be more immunogenic and lead to improved outcomes, although the overall study was negative. So in this Checkmate 901 comparison, we got a chance to look at Gem-Cis, so all patients getting cisplatin combined with nivolumab in the experimental arm. There was an improvement in overall survival, as you can see, around 19 months versus 22 months with a hazard ratio of 0.78. This did lead to a change in the standard of care with this regimen approved by regulatory agencies for cisplatin eligible patients only. The toxicity profile was as expected with the addition of a PD-1 inhibitor, nivolumab, with the immune adverse events, and of course the toxicities of chemotherapy. So nothing unexpected there. Now, one of the most interesting findings in this study, although the overall study was modestly positive, like I showed you, median survival around 22 months, but was the complete responses. So when you see here, the overall responses improved from 43% for cisgem to close to 58% for cisgem-nivo. The complete responses in 22% with cisgem-nivo versus 12% with cisgem. But if you look at the duration of complete response, that's really impressive for GemCis-nivo, approximately 3 years, 37.1 months median duration of complete response for cisgem-nivo versus around a 1-year duration response for cisgem. So this made us look at this population more. Who could these patients be who are achieving these durable complete responses? we hypothesized that this is probably the lymph node only metastasis patients. We've known historically that this group of patients responds better with cisplatin-based combination. So when you look at this lymph node only group and did a deep dive, you see here in the lymph node only group shown on the right-hand side, the overall response rate is almost 82% for cisgem-nivo versus 64% for cisgem. And the CR rate is very impressive, 63% CR rate for GemCis-nivo versus around 34% CR for GemCis. Again, this is the lymph node only group. And so this was impressive. And so we felt that in the lymph node only group, GemCis-nivo deserves a strong consideration given the high CR rate and the durability of the CRs with the median duration of CR overall of 3 years. And in fact, in the lymph node only group, it was around 4 years. So now moving on to the next class of agents, this is antibody drug conjugates. This is the era of lots of ADCs coming out. So look at enfortumab vedotin here. This is an MMAE payload antibody drug conjugate that binds to the surface protein Nectin-4. In monotherapy trials, the objective response rate was around 40 to 45%. And so this led to a phase 3 trial, which compared EV versus historical chemotherapy in post-platinum and PD-1 L1 inhibitor exposed patients. And as you can see here, EV led to an improvement in survival, and also the response rate held up. So the survival around 12 to 13 months median. So this led to a change in the standard of care and arrival and enfortumab vedotin. Of course, the key toxicities with EV are the cumulative neuropathy in the early maculopapular rash, which occasionally can be very severe with Stevens-Johnson syndrome. And so you really had to watch out in the early going in the first month, especially looking for this skin rash. Now, I'm going to cut to the chase and get to EV Pembro here. So there were phase 1, phase 2 data which showed that EV plus pembrolizumab was very promising in the first line cisplatin ineligible setting. So this led to the EV 302 trial, which compared EV pembrolizumab versus first-line platinum-based chemotherapy. And this was a trial that allowed both cisplatin eligible and cisplatin ineligible patients. Now, I want to highlight here that although this trial included cisplatin ineligible patients, i.e. some PS2 patients, they were very well selected. So I've highlighted here down below, if patients were enrolled with PS2, they were also required to meet hemoglobin 10 at least, GFR 50 at least, and no class 3 heart failure. So these were good PS2 patients, and only a few PS2 patients, less than 5% were enrolled, but they were allowed as long as they were well selected. Now, at the bottom line is this study was strongly positive and led to a change in the standard of care, leading to EV Pembro as the preferred first-line therapy for most patients with advanced urothelial carcinoma. As you can see here, the median PFS doubled from around 6 months to a year, hazard ratio 0.48. Median survival also doubled approximately from around 16 months to 34 months, hazard ratio 0.51. So very impressive outcomes. We're crossing 2 years now, as you can see, more than 2.5 years now for median survival overall. When you look at the subgroups, there was a benefit for EV Pembro regardless of PD-L1 expression, cisplatin eligibility or not, and metastatic disease site, visceral mets versus lymph node only. However, one thing I want to highlight is there was not a differentially greater benefit in lymph node only group, unlike what you saw with GemCis-nivo. But there was clearly benefit across all groups, regardless of sites and metastases. The objective response rate improved to 68% for EV Pembro versus 44% for Gem Platinum. The CR rate around 30% for EV Pembro. So really, overall, very impressive outcomes for EV Pembro, which led to this change in the standard of care, with EV Pembro now being the preferred regimen. When you look at the median duration of response, again, 68% response rate, median DOR almost 2 years, 23.3 months. When you look at the duration of complete response, even more impressive. We've not reached the median yet, but around 3/4 of patients still in CR are 2 years out. And when you look at the curves, they're flattening out. So I think the duration of CR is going to be really, really impressive with EV Pembro. And when you look at the objective responses, again, similar to the overall outcomes, you see that there's not a big differential between lymph node and visceral or metastatic sites. So this has sometimes influenced my practice, where the data for GemCis Nivo looking very impressive with the lymph node only group, and given the finite duration of GemCis as opposed to EV Pembro, where the strategy was to keep going with EV until toxicities or progression. I have in some patients gone with GemCis Nivo in lymph node only, but clearly EV Pembro is overall a very impressive regimen. Now, toxicities, as mentioned before, the early skin rash and cumulative neuropathy, and this was similarly seen here with the EV Pembro combination with the immune checkpoint inhibitor toxicities added. Dose interruptions and reductions were quite common, approximately half of the patients. So I wouldn't be shy to dose reduce for toxicity, given the impressive outcomes despite these dose reductions in EV302. Now, what about a biomarker for EV? So really protein expression, gene amplification have all been looked at. In a monotherapy setting, the gene amplification of Nectin-4 looked impressive. But what impressed me was even in the non-amplified group, there was a 32% response rate. So in my mind, it does not help very much to select patients based on amplification. When they looked at protein Nectin-4 protein expression, again in the EV Pembro combination EV302 trial, there was not any significant trend. So regardless of Nectin-4 expression, there was improvement in outcome for EV Pembro. So there are several IO rechallenge scenarios that we have to think about now, given what you already heard with the emergence of perioperative immune checkpoint inhibition. What do we do with EV Pembro in patients, for example, who had previous GemCis Durva neoadjuvant or adjuvant nivolumab? So this is an emerging area. There's some data emerging, but we still need more data for sure. This is a small retrospective study that looked at EV Pembro in patients who had been exposed to previous immune checkpoint inhibitors. And as you can see, the outcomes look impressive, 48% response rate, but the median PFS and survival don't quite look like EV Pembro looked in the first-line treatment-naive setting, right? So this is suggests that previous immune checkpoint inhibitor therapy does impact EV Pembro activity, but we need more data. This is a small study of around 40 patients. So ICI monotherapy rechallenge does have activity in a small group of patients, but we need to select patients carefully. And indeed, if you select patients very carefully, like in this study here, these were patients who had a great quality of response to previous immune checkpoint inhibition, had CR or had completed therapy on the trial, and then received pembrolizumab again. So in this highly selected group of very sensitive patients to previous therapy, they had a 40% or so objective response. So really well-selected patients can have a response to immune checkpoint inhibitor rechallenge. And indeed, some trials are looking at it. The phase 3 trial is going to look at rechallenge Pembro plus sacituzumab govitecan through the cooperative groups, as shown here in the design. The SITC suggests that if you had prior adjuvant or peri-op immune checkpoint inhibitor therapy, if you're more than 12 weeks out, you could consider rechallenge. And they based it on the rationale that the immune checkpoint inhibitors are washed out in about 3 months because of their half-life of 3 to 4 weeks. But I think this is just an opinion. Is we need more data to look at what the right cutoff might be to try the combination. Now, sacituzumab, I'm going to go really quick here. Sacituzumab govitecan was initially approved based on response rate only and only in the US. But later, the phase 3 trial, TROPiCS-04, was negative, done in the post-platinum PD-1 inhibitor setting, in the third-line setting, mostly because the neutropenic complications unfortunately compromised the outcomes. However, SASI plus pembrolizumab in the post-platinum setting has looked like it is active with a 40% response rate, median PFS 5.3 months. Perhaps if you give it earlier on in the switch maintenance post-platinum setting, it's more active. There, the median PFS was around 11 months in the switch maintenance setting, avelumab plus sacituzumab compared with avelumab alone as presented at ASCO this year. There are other TROP2 targeting ADCs arriving or being evaluated with the MK2870 and datopotamab deruxtecan. So these need further evaluation. Where do we go with TROP2 ADCs? This is a combination of sacituzumab plus EV that looked very promising in a phase 1b study, and further evaluation of the double ADC combination plus a PD-1 inhibition is ongoing as we speak, as shown in this slide, and as well as in this slide here. And then there are other combinations that might make sense with TROP2 ADCs. This is a study looking at Dato-DXd in several combinations, including immune checkpoint inhibition, and as well as platinum-based chemotherapy. What about TROP2 ADCs with a topo-1 isomerase payload combined with a PARP inhibitor, combining a DNA-damaging agent, toxin plus PARP inhibition has always been intriguing. Unfortunately, they have been toxic in breast cancer where it's been done. But a strategy might be sequential sacituzumab and a PARP inhibitor instead of combination. Do it in sequence might be a smarter way of getting these two drugs in. And this strategy is being tested with a specific PARP1 inhibitor, which might be less toxic than a non-specific PARP inhibitor, combined with Dato-DXd in this Petra trial. And there's a new TDXD ADC on the block, which is a HER2 targeting ADC approved now in IHC 3+ patients based on a pan-tumor basket study. There was a response rate of around 39% in all bladder cancer patients, very high in IHC 3+ patients, 56.3%. So I'm going to cut to the take-home message slide here, given the interest of time. Disitamab vedotin is being looked at. This is a new HER2 targeting ADC with an MMAE payload, and in combination with PD-1 inhibition looks promising and is being evaluated. In 15-20% of patients, FGFR3 mutations or fusions are seen. Erdafitinib has shown improved survival in patients compared to chemotherapy in the post-immune checkpoint inhibitor setting. Erdafitinib compared with chemo was showed an improved survival hazard ratio of 0.64 with immediate survival just around 1 year, response rate 45%. There are toxicities for erdafitinib, dry eyes, dry mouth, and the visual toxicities, but these can be managed. There are novel FGFR3 specific inhibitors, unlike the erdafitinib, which is a pan-FGFR inhibitor, which are being evaluated. And just to give you a flavor, EV plus erdafitinib done in this study look promising. And in fact, a study is going to combine EV pembro with a FGFR3 specific inhibitor, LOXO435. So really, at the end of the day, I'm going to cut to the chase and say that while for most patients, EV pembro is the current standard of care, I think Gemcis, Nivo, and Gem Platinum followed by avelumab, as well as pembro monotherapy, can all play a role in select patients. The impact of prior peri-op PD-1/L1 inhibition on advanced disease therapy needs more study. Erdafitinib and TDXD have emerged as options. Erdafitinib based on a phase 3 trial. TDXD is just based on a accelerated approval based on a pan-tumor basket study. So we need further data with that agent. Other promising ADCs are emerging as shown here, especially in EGFR HER3 bispecific, and look for other TROP2 ADCs. And also always think of trials first for these advanced disease patients, because we're still not curing most patients. Thank you.
Thank you, Dr. Sonpavde, for that wonderful insight on this immune checkpoint inhibitors and the novel drugs, and also these combinatorial approaches. So moving on to the next session, I request Dr. Rachan Shetty to chair this session. Dr. Rachan Shetty is a senior consultant in medical oncology at AJ Hospitals in Mangalore. And we have the Meet the Faculty session. So all three faculty will discuss the cases which will be presented by our young and enthusiastic medical oncology fellows. Over to you, Dr. Rachan.
Thank you, Dr. Vishwanath. At the outset, I would like to thank all the eminent speakers who have joined this session. And I would like to introduce postgraduates, Mr. Dr. Narendra Gokulnathan, who's a second-year academic registrar at Apollo Hospitals, Bangalore, and Dr. Rohan Gupta, senior resident, third year, Department of Medical Oncology at MS Ramaya Medical College, Bangalore. And over to Dr. Narendra Gokulnath. Thank you.
Good evening, everyone, and good morning to my friends in the US. So I would like to present a locally advanced muscle invasive bladder cancer with the key pertinent questions of bladder preservation in the immunotherapy era and the trimodality therapy eras. So our patient was a 57-year-old female with a comorbid of hypertension, and she had presented initially in April 2023 with gross hematuria and burning micturition. Cystoscopy was done in April 2023. There was a papillary tumor arising from the left lateral wall and the bladder base. There was no trigonal or ureteric involvement, and TURBT was done. It showed a high-grade urothelial carcinoma, and no muscle was identified in the specimen.
Sorry to interrupt. Could you share your slides?
Sir, it's already being shared by Dr. Vishwanath, sir.
Okay.
It's not moving?
No,
It's moving, sir.
is it? Because I can only see, I'm still seeing Dr. Guru Sonpavde's screen.
Okay. Is it not moving? Others?
It's going on,
There
sir.
it is. There it is. There it
Now
is.
it is.
There it
Okay,
is.
thank you.
There it is.
So yeah, check cystoscopy post initial TURBT was done, and there was suspicion of residual lesion, and there was a repeat PET-CT done which showed persistent posterior bladder wall thickening with reactive pelvic nodes and no distant disease. Repeat cystoscopy and TURBT was done, and the tumor was recurrent in the bladder, neck, and the posterior wall, and associated carcinoma in situ was also found. So histopathology showed high-grade invasive urothelial carcinoma, which was grade 3, and with definitive muscle invasion this time. Lamina propria and deep muscularis propria were involved. IHC had GATA3 positive, CK7 and CK20 positive, with a high proliferative index more than 50%, and PDL1 was 11%, and it was a PT3A N0M0 tumor. So the patient underwent radical cystectomy, and they were taken up for adjuvant chemoimmunotherapy. Adjuvant chemoimmunotherapy was decided on because it was a recurrent tumor, and we didn't want to take chances. So, and she was cisplatin eligible. So we took a gemcitabine cisplatin along with sandwiched the nivolumab as well. So gemcis and followed by adjuvant nivolumab, and she completed 8 months of adjuvant nivolumab based on this Checkmate 274 and dropped out in view of logistics. And she still remains on follow-up with a DFS of 18 months. So my questions to the panelists are, in this kind of a situation, if the patient did not want to undergo cystectomy, and where will RT fit here? If is there any RT versus IO trials that are ongoing? Do we have any data, or is it a data-free zone? Any of the panelists can take this, actually.
Yeah, I found this case a little interesting, just to highlight that I think this patient was not, I'm not sure if this patient was cisplatin eligible preoperatively, but I would have currently, if I saw the patient, I would offer Gemcis plus durvalumab, 4 cycles, followed by 8 more cycles of monthly durvalumab based on the current data. If I saw the patient like you presented, like had cystectomy first and then coming in the adjuvant setting, given that patient is cisplatin eligible and did not receive neoadjuvant cis, I think I would have done with what the data have shown is Gemcis durva. I would be comfortable giving Gemcis durva. It's like it's adapting the Niagara data to the adjuvant setting, given this patient did not receive neoadjuvant Gemcis. But regarding the radiation question, yes, I think that is an option. We offer it as an alternative in patients who are not cystectomy candidates. The retrospective study, I know Dr. Mallya showed the retrospective data, but I think those were well-selected patients, as you know, tumors less than 7 centimeters, no CIS, no multifocal CIS, no hydro. So in select patients, yes, I think it's an option, but it's important for the patient to understand that we don't have a good phase 3 study to show the equivalence of chemoradiation versus the neoadjuvant chemo followed by cystectomy approach. So I think that we offer it as an alternative in patients who are not fit for cystectomy. And I personally, I don't believe they're equivalent. I don't think we're gonna ever have a phase 3 trial. I think the Tata Memorial Hospital is trying to do a phase 3 trial. Maybe we'll have something from that trial, so we'll wait and see.
I think the other thing too is that the adjuvant, there is an interaction. At least we think there's an interaction between cisplatin and immune checkpoint therapy. We saw that with the atezolizumab trial, and so now that we have more data, I think it's really a reasonable thing to combine the checkpoint in the adjuvant setting if you're going to give adjuvant chemotherapy, rather than giving it sequentially.
So I would like to add something here. If you have if the other panelists are finished saying what they had to say. So if you go back to the slide where the first TURBT was done, I went through the slides. Now, this is exactly what happens. Sometimes when you do not have muscularis propria in your TURBT, and I don't know, I don't have any information when the patient had a high-grade non-muscle invasive bladder cancer, was any intravesical therapy offered, because things seem to have progressed, and that could have been avoided provided the patient had a proper TURBT, which is, like I mentioned, the cornerstone of all bladder cancer management, a very well done TURBT. And muscularis propria has to be seen in your TURBT. If it is not seen, and if the histopathology is high grade, the patient definitely deserves a restaging TURBT. Coming to your question about radiation therapy, yeah, of course, like Dr. alluded to, that patients who are not willing for cystectomy or not fit for it can be offered the trimodality therapy, but it requires very stringent follow-up. It's not a walk in the park. Sometimes they are probably better off getting a radical cystectomy and be done with it, followed by adjuvant or perioperative therapy. But bladder preservation schedules are very stringent.
Thank you, sir. So my next question to the panelists is naturally a financial oriented one, coming from an LMIC. So shorter duration of adjuvant chemotherapy, immunotherapy, or shorter duration like a neoadjuvant. So there is data in the recent ASCO paper by Dr. Galsky had shown that ctDNA guided, we can possibly de-escalate in patients who have achieved a PCR, or we can possibly de-escalate in ctDNA negative. We don't need to give the full dose of Niagara, but it's not phase 3 data yet. But I just wanted to know if it would be medically wise to have a shorter duration of adjuvant immunotherapy in certain patients, and if so, what could be the criteria for a shorter duration of therapy?
I think Dr. Guru sir would take this question.
Yeah, I can comment on that. So basically, the data we have right now is with neoadjuvant Gemcis Durva from the Niagara trial, followed by 8 more cycles of monthly Durva. And it's very difficult to tease out the differential impact of the adjuvant component. You mentioned the lung data. So the lung is a unique situation. They had a couple of phase 3 trials. One had just the neoadjuvant chemo IO component. The other one had neoadjuvant chemo IO plus adjuvant IO. And in fact, they did interestingly an analysis. They were both trials from BMS. So they could actually compare these two trials, right? And so what they found was that the peri-op IO was better than just neoadjuvant IO. In this somewhat, it's an imperfect, but it's a trial patient level analysis from 2 big phase 3 trials. It's a different cancer, so that's again the caveat. So at the moment, and also when you look at the Niagara, you see that there is an early benefit with the chemo Durva. You see a separation in the EFS curves happening even before you go to cystectomy. So my own approach has been to just offer everybody, my de facto is everybody get Gemcis Durva followed by adjuvant Durva. There are some patients who want to avoid the immune checkpoint inhibitor toxicity and understand the caveats. And so in those patients, I've gone with Gemcis alone neoadjuvant, followed by adjuvant Nevo if they don't achieve PAT-CR. So that's, I think, acceptable. But my bias is that the neoadjuvant chemo IO provides an early benefit beyond the chemo alone.
Yeah. And,
So, yes, sir.
Yeah, we'll go ahead.
Yes, my next question was to Dr. Ashwin, actually, the uro-oncologist. So for patients who are ineligible or refuse immunotherapy due to financial constraints post-cystectomy, is there any indication to do a more extensive lymph node dissection or be more aggressive with the surgical clearance? Is there any change in the pattern of surgeries done just because they can't afford the adjuvant treatment?
No, that is definitely not something we consider. But our standard, we always do a standard pelvic lymph node dissection. If there is any preoperatively, we find that there is any node that requires an extended pelvic lymph node dissection, we definitely go ahead and do it. But that is not a consideration that, because of the financial reasons that we are doing a more extensive surgery.
Yeah, I think you've completed your talk. And very well presented, Dr. Narendran.
Thank you, sir.
This is what we see in real world bladder cancer patient receiving chemo followed by immunotherapy. But immunotherapy is still very expensive in India. But people who can afford it makes a difference.
I just had a small thing to add, sir. We also had an interesting patient actually. So till the time of MDT decisions, our patient was okay with cystectomy. But at the end of our neoadjuvant therapy and TURBT, our patient was not very comfortable with the idea of a conduit or a neobladder. So this is that kind of a patient. So very similar disease profile, T2N0 was there. But as an alternative, we went to the triple modality therapy. We went ahead with the RT followed by an SBRT boost. Full dose therapeutic radiation was given. No further adjuvant treatment. He was not willing for further immunotherapy as well, and he was not willing for cystectomy. So, have you seen such cases in your practice who are okay with cystectomy upfront, but when it actually comes to it, I mean, it's quite natural. But have we seen such cases, and what do we do with them, and where do they fit in the post-IO era? So that's all. So any of the panelists can please take this.
The senior consultant, Dr. Daniel, would you like to take this question, sir?
Sure, absolutely. So this is a difficult question because so patients even up front say, look, I don't want my bladder out. And so when I was at Columbia, we actually looked at this and we actually collected data of patients who refused cystectomy. And overall, about 65% of patients were able to retain their bladder at 5 years. The majority of patients tended to relapse within about 6 to 8 months after the completion of neoadjuvant therapy. That's where the critical time seems to be, at least from those particular trials. So yes, I think that they can be watched. The caveat is that they can potentially develop metastatic disease. I believe there's about an 8% chance, 4 to 8% chance of metastatic disease developing. So it's sort of a buyer beware in that situation. You can keep your bladder, but you have the risk of developing metastatic disease, and those are the stats that have an informed decision. We're actually looking at a trial in SWOG to look at radiation therapy in this situation as well. Maximum treatment with dose-dense MVAC or GemCis, and followed by radiation therapy. So there are trials that are looking at this particular question. There are also trials that are looking at potential neoadjuvant enfortumab and pembrolizumab. That's really where our next frontier is going to be with this disease.
Okay. Thank you, Dr. Narendra. Very well presented, and I'd like to thank all the panelists. We'll go on to the next case, which will be presented by Dr. Rohan Gupta from MS Ramaya Medical College. Over to you, Dr. Rohan.
In India and towards the fields in the US. So today we'll be discussing a patient who had recurrent metastatic urinary bladder cancer. So coming to the patient profile, this was a 70-year-old male presented to the urology OPD with hematuria and was evaluated for the same. CT-KUT was done, which showed a distended bladder, thickened bladder wall, soft tissue used. Underwent TURBT, HPE showed PT2N0. Deep muscle invasion was present, focal squamous and sarcomatoid differentiation. PET-CT was done, which showed that there was a residual bladder lesion and mild external iliac node activity, which was discussed further with a nuclear lens, which was not positive for uptake per se. So initially, this patient received the neoadjuvant chemotherapy. The advanced phase in reduced creatinine clearance, patient was deemed cisplatin ineligible, and took gemcitabine and carboplatin 3 cycles, day 1, day 8 phases, every 21 days. PET-CT was done post. There was a residual bladder lesion with still mild nodal uptake. Now, patient opted for bladder preservation even when cystectomy was offered to the patient. So, the patient underwent CT-RT. This was in June 2024. Did 5 cycles of carboplatin AUC with definitive radiation. Now, 25, this patient again had a recurrence. There was a new metabolically active lesion in the left epiquine lung segment. There was new lymphadenopathy, hilar and prevascular nodes. So the next step, of course, was to do biopsy from the lung. CT-guided biopsy from the lung was done. It showed a poorly differentiated carcinoma. Upon further IHC, it was positive for CK7-GATA3 and uroplakin, which was consistent with urothelial carcinoma. Also, to rule out lung cancer, we did of a TTF1 upsine as well, which were negative as well. Now, despite neoadjuvant chemotherapy and concurrent CTRT, patient did develop metastasis within 8 months finishing of therapy. And again, the patient was very reluctant. A lot of therapy in this particular patient was guided by the patient's choice and reluctance towards therapy. So they declined any further chemotherapy, necessitating an alternative systemic therapy. Now, the next thing that we decided was to go with nivolumab. What was the evidence that we found in nivolumab based on the CheckMate 275 trial? Even though it was a phase 2 trial, the ORR was about 19.6% overall, and ORR increases with the PD-L1 expression. Again, guided by the patient wanted, did not want any further testing. So PD-L1 was not done, but after nivolumab was given. In this particular trial, the median OS was 8.7 weeks. Now, why immunotherapy? Platinum-based chemo was exhausted and patient refused any further cytotoxic agents. Nivolumab offered better tolerability and durable response. So benefits in this case was that patient remained in ECOG PS1. There were no major clinical or laboratory adverse effects for the patient even after the 8 cycles, and the patient did not have any symptoms per se. So the discussion points that I have are: would this patient have been fit for perioperative durvalumab even though the patient is ineligible and was not upfront ready for surgery?
Rachan, you're muted.
So, eminent panelist, any of you can take up this question, sir.
So just to clarify, this patient had radiation, did not
Yes, sir.
actually have cystectomy. Is that right?
Yes, correct, sir. He refused cystectomy, and as we saw that in this real-world patient, the treatment was guided along with patient's choices as well as whatever we had to offer.
Yeah. So I mean, in this patient, just talking about this patient, recurred quickly within a year after gem platinum, with metastatic disease now in the lung and lymph nodes. I think I would treat him like first-line metastatic disease with the EV pembrolizumab. Patient has not been exposed to PD-1 inhibition, and even if he was, even if he was exposed, but beyond 3 months from immune checkpoint inhibition, I would do EV pembro. I find it hard to deny patients EV pembro, given the synergism seen with EV pembro, even if they were exposed more recently. Actually, we need more data in this situation, of course. But obviously, in this patient, ideally, I would have given Gemcis, Durva, neoadjuvant, followed by 8 more months of monthly Durva, like I already said before. But this is somewhat unique patient that had chemo and followed by radiation, I guess.
Sir, I would like to ask a question. In this patient, received carboplatin. Carboplatin is inferior to cisplatin in bladder cancer. So, is there a role of carboplatin in bladder cancer? Or does it really?
We have typically not used carboplatin concurrently with radiation. Usually use cisplatin, 5-FU-mitomycin, or gemcitabine. We'll have to hear what Dan has to say about this, but typically we don't use carbo with radiation.
I'm pretty much a purist in that situation. I don't use carbo with radiation therapy. I'll use one of the three that Guru just mentioned a moment ago.
And this particular patient had a sarcomatoid differentiation. And how well does durvalumab or any immunotherapy work in a sarcomatoid variant of urothelial carcinoma, sir?
Do not have much data. As you know, sarcomatoid RCC, it works really well. I would not in the Niagara trial. Actually, patients with variant histology were allowed, even if they had majority variant. Now, only 20% or so of patients had variant histology, and so it's difficult to really have a strong statement on this. But in general, as long as you have a urothelial component, I would not deny the patient Gemcis Durva.
It's interesting. The one variant that does seem to have a biological difference, and this has been published by Bernie Bachner recently, is the plasmacytoid variant that has a high level of Nectin-4 expression. So this is whether that justifies giving EV Pembro or not in this situation, I think is something we need to determine in the future, but there is a difference there.
Oh, over to you, Rohan. If you have any.
Already discussed the current state of IOs in bladder cancer, but given the chance, so would you be using pembrolizumab first, or like we use nivolumab first, as the patient just wanted a single therapy she could afford at this point of time?
For monotherapy, we have strongest data for pembrolizumab, of course, because the phase 3 trial in the post-platinum setting with positive survival improvement was pembrolizumab. Of course, nivolumab and avelumab are also available, but I prefer to use pembrolizumab in most of these cases of monotherapy.
Monotherapy.
One of the advantages of Pembro's schedule that you can actually give a 6-week treatment. Giving it every other week is a little bit more challenging in some people. So that's something I think that needs to be that is a consideration.
I would like to ask Dr. Daniel, which molecule works better, durvalumab or pembrolizumab in the real world practice?
Which works better?
Yes.
No, unfortunately, we don't have any data. I wish we did. We know that 2 of the other checkpoints lost their accelerated approval. The one I think that was most disappointing was tezolizumab, since we did see some very interesting preliminary activity. But there are a lot of reasons why that lost its approval. Partly trial design, possibly that's an inferior checkpoint in the situation.
Dr. Rohan, do you have any more questions to ask?
I think Sir has explained already regarding the choices of immunotherapy in this patient. The only doubts I have are in a low resource setting like India. What would be the next choice of therapy once this patient progresses on nivolumab?
Well, in your case, you've done gem platinum and nivolumab now, I guess. So of course, EV would be the next natural choice. And of course, if you have the FGFR3 mutation or fusion, erdafitinib would be a good choice.
And let's also not forget HER2/neu. And we have a pan approval in the United States for trastuzumab deruxtecan, and that also does have activity. And there are other trials with HER2/neu based therapy.
I would like to ask a question to Dr. Daniel. CGP testing in bladder cancer. When do you use it? When they progress on treatment, or upfront for all patients it is done?
Well, I like doing the next generation sequencing right at the beginning of metastatic disease, when they're first diagnosed with metastases, because then if they do progress, you don't have to wait for your sequencing to come back. You could make the decision to go on a targeted treatment or to go on other chemotherapy at that particular point. So I like doing it at that time. For a patient with locally advanced disease, I don't really think it pays, because you have, unless they become metastatic, because it really is not going to give you much more information as to what to do next.
Yes. Dr. Rohan, do you have any more questions?
To our urologist.
Thank you.
Yeah, thank you for getting me in, Dr. Vishwanath. So I know this discussion was about metastatic bladder cancer, but if this had presented to me, how I would differ. So this patient had a variant histology to begin with. Secondly, you gave him neoadjuvant chemo, and he still had residual lesion as well as a lymph node lighting up on PET scan. So such patients are not the best candidates for trimodality therapy. Okay, they are not going to do well. I agree that the patient's wishes had to be, that was the patient's wish. But I think the counseling right from the beginning was probably, I feel we would probably go in for a radical cystectomy upfront rather than giving neoadjuvant chemo if this had presented to our center. So because now he has reached the stage where he has gone into metastatic bladder cancer. So that's my point of view. But again, it was not an ideal case selection for trimodality therapy.
Thank you so much, all the panelists, and both Dr. Naren and Dr. Rohan Gupta for the wonderful case presentations. Now I request Dr. Rachan
So
Shetty
I would,
to give the closing remarks.
yeah. So we extend our deepest gratitude to Dr. Daniel Petrylak, Dr. Guru Sonpavde, and Dr. Ashwin Mallya for their comprehensive and insightful presentation. And your expertise and clarity greatly enriched today's session. And special thanks to Dr. Naren and Rohan for their thought-provoking case presentation, and to all the eminent panelists who actively participated in this discussion that followed. Our sincere appreciation goes to ASCO leadership for their continued guidance and support, and to ASCO international team, Mrs. Sarah Bachman and Mrs. Jessica Williams for the unwavering encouragement and help in organizing this event. A heartfelt thank you to Dr. Vishwanath for his dedication and tireless efforts in making this webinar possible, and to my fellow CPOM trustees for their constant support throughout. And to our wonderful audience, thank you for enthusiastic participation, which played a key role in the success of this session. And at the end, we would like to acknowledge and thank today's sponsors, AstraZeneca, NATCO, Intas, and OncoMinds for their valuable support. Thank you once again, and we look forward to welcoming you to your upcoming ASCO-sponsored CPOM webinars. Thank you.
Thank you.
Thank you. Thank you very much.
All, thank you.
Thank you.